We are really proud of the contribution that St. Peter's people are making to the current crisis as part of the wider effort that Oxford academics are making more broadly in their research work, medics and pharmacologists and chemists and economists and economic historians and more. And they are variously harnessing their own expertise to address the very major challenge that the virus presents and the attendant problems that it creates. And in this respect, we are proud of none more than our statutory professor in statistics, Professor Christl Donnelly CBE. Christl is a Professorial Fellow at St. College, head of the Department of Statistics here at the University of Oxford, and she's Deputy Director of the World Health Organization Collaborating Centre for Infectious Diseases. And for the past 25 years, she has worked on the statistical epidemiology of infectious diseases and focused on real-time epidemic analysis, situational awareness, or response. Christl has been involved in many intensive efforts to understand and control threats, including those relating to a whole run of previous diseases, including BSE, CJD, SARS, Ebola, Zika, and many others, and now COVID-19, of course, collaborating with numerous colleagues in the WHO, in government departments, with Public Health England, and with the US Centres for Disease Control and Prevention. Christl is a Fellow of the Royal Society, Fellow of the Academy of Medical Sciences, and has a CBE in recognition of her work. Honours and awards come thick and fast, and last week, for example, she was awarded the Zoological Society for London's Frink Medal for contributions to zoology. Christl, we honour you and we welcome you to this session. And what better way, in fact, for all of us to mark World Statistics Day than by inviting Professor Christl Donnelly to tell us about how we can use statistics better to understand and, importantly, to control COVID-19. Christl, the floor is yours.
Thank you very much indeed. Made me feel very welcome. I'm going to share my screen now. Okay, so yes, I gave this title of A View from the Coalface because it's a feeling as a statistician and epidemiologist working in infectious disease to understand transmission and opportunities for control. As you can imagine, this year has been like no other. I realize that's true for all of us, but particularly working in outbreak response, it's been a huge challenge and they've come from every different direction. So I just want to try to give you a feel for some of the results that we've produced and experiences we've had over this year. Now, there's just my name on the front of this talk, but this represents a huge number of collaborative efforts. She already mentioned that I work with people from the US CDC, Public Health England, collaborators in the WHO in many different responses that we take to different outbreaks. In terms of my own affiliation, I have both a post here at the University of Oxford in the stats department, as well as a Professorial Fellow at St. Peter's, but also in the Department for Infectious Disease Epidemiology, which is in the School of Public Health at Imperial College London. So this work is collaborative across those different affiliations. This is a slide that I've had for a few years, and I keep having to add another outbreak to it. So I've had to sort of squish up the circles. It's sort of my life in outbreaks. So the first one that I worked on in sort of real-time response was when I joined Oxford in 1995. Soon after that, there was the announcement in the House of Commons that variant CJD or VCJD had been discovered as a human consequence linked to BSE or mad cow disease in cattle. So I worked with colleagues through that summer in response. Now, it felt like a very fast-moving and intensive summer, which in some ways is odd for a disease that in cattle has an incubation period that's a time from infection to showing the signs of disease of about 5 years, and in humans even longer. But it was the politics, the policy, and the needing to get evidence to support that policy that was very fast-moving. Then foot-and-mouth disease in 2001 that was in the UK, and that was an animal-only disease but that moved on a much faster time scale. So responses had to be quick, otherwise they'd be too late. In 2003, collaborated with colleagues in Hong Kong to analyze data on SARS, sudden acute respiratory syndrome, which was the first major coronavirus that I'd worked on. And you see other things since then, the pandemic influenza in 2009, MERS, which is another coronavirus that stands for Middle Eastern Respiratory Syndrome. And the animal reservoir for that is camels. So it was transmission from camels to humans that started a number of small outbreaks, and then there's some human to human transmission, but a lot of it can be avoided through what we call non-pharmaceutical interventions. These are social distancing, sort of disinfection, routine sort of personal protective equipment, as you see in hospitals, and now we wear in lots of settings, but that was sufficient to control most of the spread of MERS. More recently, Ebola and Zika, including multiple outbreaks in DRC, the Democratic Republic of Congo. But as I said, this has been a year like no other. My work on this started with colleagues in middle of January. And the first thing that we looked at, it's not going to be a whole talk of tables, so don't worry, but I want to be able to point out some of these numbers. So our first report looked at when we had only 3 exported cases confirmed outside of China.
With gorgonzola.
So the
Pizza
epidemic
quattro
started,
formaggi with salami.
the epidemic started in Wuhan area in China, and there were initially cases that were detected there. And it wasn't clear, of course, how many cases there were in that area, because as a new disease is identified, it is, of course, difficult to identify every single one of those cases. But by the time there were 3 cases exported, it was already ringing alarm bells that suggested either the transmission was happening preferentially among international travelers, or more likely that it was that those travelers were an indication of a larger risk that was happening in Wuhan area. So we used formulae to look at the risk of a particular case in Wuhan being exported. So showing up in a person who had left Wuhan, being asymptomatic, not showing the symptoms when they got on the plane, but later developing the disease. That took into account the number of people flying internationally out of Wuhan airport. It took into account the size of the population, and we looked at different scenarios, either 11 million or 19 million being the people that if they flew internationally would fly from that airport. How many days you can detect virus in an individual, whether that's 8 to 10 days, and use that to estimate the number of cases that we thought were already in Wuhan. And our best estimate was about 1,700 cases, based purely on 3 cases being observed outside. Now, there's quite a wide level of uncertainty. So statisticians, we like to give a measure of not just an estimate, but how uncertain we are about that. And it ranged from about 400 to over 4,000, but still considerably more than the dozens of cases that had been reported in Wuhan up to that point. By the 22nd of January, that 3 cases exported had become 7, and that upped our central estimate to 4,000, with a range of uncertainty from 1,700 to almost 8,000 cases. So considerably more infection was estimated to be in Wuhan than had yet been uncovered. Now, I said that's not surprising, given that when a new disease arises in an area, it's very difficult to determine immediately what the criteria are. What are the symptoms? What distinguishes this disease from others? Getting testing up and running, because of course, first a test has to be developed and then it has to be applied. So it's not surprising that there were cases missed, but it was important for us to understand the magnitude of that. One of the reasons for this is that we can then use it to estimate how quickly the disease is spreading. And the way that we do that is by looking at the range. So the central estimate, as we published on the 22nd of January, was about 4,000 cases. And so we can estimate if we started out with initially, say, 40 cases having been infected by animals. We know that this is a disease that has suddenly appeared in the human population. It has sufficient similarities genetically to other coronaviruses that have been seen in bats in areas of China. And so that suggests that even if it went through another species to get to humans, it probably originated in the bat population. But say that 40 individuals had been directly infected by the animal reservoir. So it was an animal to human transmission for say 40 people. And that may have concentrated in a market where there were cases first detected. But if that's the case, then the growth from initially 40 cases in early December to 4,000 cases by the middle of January corresponds to a central estimate of about 2 for R0. Now, R0 is something I used to have to explain to a completely naive audience in not having heard that at all. Of course, we've heard a lot about R, but just to make clear, R0 is the average number of new infections one infection causes in a fully susceptible population. That's where the naught comes, because it's at the start. And we believe that because this was a new disease in human population, that the population in China, as well as the population of the world, were likely fully susceptible to this. We hadn't seen something like it before. So that's the best case is the 2.1. The central estimate, probably the most likely thing, is about 2.5. Now, what are the key things that you should draw from somebody telling you what an R0 estimate is? The first one is it greater than 1? If it's greater than 1, then that means that you'll see an increase in cases. Now, that's not surprising if we see, that we estimate that we had 4,000 cases by the middle of January, and we think, dozens had been infected directly by the animal source. Of course, it was growing. But it also tells us by the magnitude of it, how much transmission we need to prevent or control to turn an increasing trend into a controlled decreasing trend. So let's say that number, just rounding it to make it easy, is 3. So if R0 is equal to 3, then we need to prevent 2/3 of the transmission. So that calculation is 1 minus 1 over R0, 1 minus 1 over 3, or 2/3. So we need to prevent 2/3 of the transmission that was naturally happening to begin with in order to turn that increasing trend into a decreasing one. Now, there's another challenge that comes, and I'm going to look back to the work that we did with SARS in Hong Kong, which is you not only need to know how fast a disease is spreading, but how serious it is. And so what we first think about in looking at that is the case fatality ratio. That's the proportion of cases, those people that show symptoms of disease, that go on to die from the disease. And this shows the number of cases confirmed each day in Hong Kong for cases of SARS. This is in 2003, showing you from February to May. And you see the cases peaked in late March. This infection appeared at almost exactly the same time of the year. It started out in December and then was picked up early in the year in 2003. And then relatively rapidly, we thought of it at the time, spread internationally. But it was much more easily controlled. And I'll touch on the reasons for that later. One of the things I wanted to point out with this graph is that by the time you get to the 2nd of April, and that arrow shows you here, there had been 925 cases. So 925 cases sounds like a lot of cases in order to estimate something relatively simple, which is the case fatality ratio, the percent of cases that will die of the disease. The problem with estimating this quantity, even if you have over 900 cases in the middle of an outbreak, is that it takes a time to go from the time somebody is diagnosed as a case to find out whether they will survive or sadly succumb and die from the disease. And so by the 2nd of April, although we had data on 925 cases, some 86% of those didn't have an outcome yet. They were still in hospital. So even though it seemed like we had a lot of data, we didn't know what the outcome was going to be. And that's quite important for estimating this quantity of what proportion of people will die when you're in the middle of an outbreak. Now, a very simple way to estimate that, and it works really well if you're at the end of an epidemic, is the CFR, this is the case fatality ratio, is the number of deaths divided by the number of cases. It's straightforward, it's in some sense does what it says on the tin. The problem with that is, as I've mentioned, even at the point of the 2nd of April, 2003, we had over 900 cases, so that could be our denominator, but the majority of those were still in hospital. So although we'd seen some deaths from those cases, we didn't yet know how many of those would go on to die later. And so although this was a simple method and was being used by the WHO, the World Health Organization, to estimate this case fatality ratio, and was shown openly this is how the calculation was going, there were these issues with it. So we suggested a couple of alternatives. A simple alternative is the number of deaths divided not by the cases, but by those that have had outcomes. So the number of deaths plus the number of recoveries. So essentially, what proportion of those people that what happened to them were deaths? And so that's another estimate, and I'll show you why that's a better estimate of the case fatality ratio. Now, there were fancy statistical ones as well that had nice graphs like this that we won't get into the formula for. But even this simple method 2 will perform much better than method 1, which was being used. This shows over time for Hong Kong, using the real data, how the estimates change. So this first estimate is shown with a diamond, and the height of those bars shows how uncertain this estimate is. The problem is that this uncertainty doesn't take into account how many people are still in hospital. It only takes into account we had 925 people, and then we estimate the proportion. So the estimate that was being produced and published by the WHO at this point was, as I said, deaths divided by cases. So it gave a death rate of just a couple of percent. If we used alternative methods, and we concentrate here on the one shown in it with a triangle, deaths divided by deaths plus recoveries, the estimate was more like about 10% of deaths, with considerably greater uncertainty because there weren't so many outcomes that we'd observed by that point. And you see over time that this simple estimate that had been used was growing. And the reason that it was growing was because eventually we will see all the deaths that will result from the cases, and we will have the true estimate, but it's biased. So it's artificially lower at the beginning, not because of anything that someone's doing to hide data. We do call it censoring, but it's not censoring in the sense of not telling people. It's censoring in the sense that we haven't seen the outcomes yet. And so that caused these estimates that were being produced to appear to increase, where in fact what it was they were biased to begin with, and they were going to the truth. And here I shown you that what was the eventual death rate in these individuals in Hong Kong, which was about 13%. And you see that it matches well with the estimates even as early April, when we do deaths divided by deaths plus recoveries. So it's really important when we're doing real-time analyses to allow for the events we've seen and the events we haven't yet seen. There may be more consequences by infections that have already happened by today that we haven't yet seen in terms of our numbers. But this could be quite confusing. And in fact, it led to press reports concluding that SARS was becoming deadlier, and journalists noticing that the death rate was more than double. And this wasn't because anything was changing about the virus. It wasn't becoming more deadly to individuals, but it was that the estimate was becoming better over time. It had been biased and was becoming less bad over time. So these are in late April 2003. And so the day after this, on the 26th of April, the group that I was working with Roy Anderson and other colleagues, we published our best estimate based on the data in Hong Kong. And this is how it was reported on the morning of the 26th of April. So the research by a British scientist, which of course it was a team, said that SARS could kill between 8 and 15%. So that gives you that range of estimate. The WHO had predicted 5 to 6%, and this was using the deaths divided by cases, so it was biased down. And then they said the WHO said its estimate was more reliable because it had looked at infections around the world, as opposed to what we'd been doing, only looking in Hong Kong, but in great detail. An hour later, this had been adjusted, that it wasn't researched by British scientists, it was researched by Professor Roy Anderson. And then the quote was that a WHO spokesman said, Professor Anderson was a top-class professional and his findings were probably accurate. Now, this, of course, is not how you should judge whether an estimate is accurate by who's presenting it to you, but to actually go into the methods. And that's why I wanted to show you that there was a good reason why we were saying, you know, that yes, we looked at the same data, but because we allowed for events that had yet to come, these are the deaths that had yet to be observed, our estimate of the death rate was higher and was shown to be more accurate because, of course, by the end of the epidemic, you will have observed those cases. Now, it's orders of magnitude more difficult to estimate the appropriate figures for COVID-19. The reason for that is because you have a substantial portion of asymptomatic cases. So that means that you've got people that are extremely difficult to detect. And if you're not detecting those as cases, there's going to be a difference between the case fatality ratio, so what proportion of cases go on to die, and infection fatality ratio, which is what proportion of those who are infected go on to die. And when you're thinking about the true severity of the disease, it's the infection fatality ratio that is most determining of how seriously you need to take this. And so we needed to look at that. Also, we found that there are substantial differences between different age groups. So we found that older individuals and those with particular health risks have a higher risk of death for COVID-19. Men tend to have a higher risk than women, and there are ethnic group differences as well. And so all of these makes for considerable complexity and difficulties when comparing one country's statistics to another. Partly because they have different groups of people, they may have different prevalence of particular health risks, they'll have different ethnic group mixes, but also depending on how available testing is, they may be testing a smaller or greater proportion of those people with symptoms that are actually coming forward with disease. These are the sort of overall estimates that we obtained and are similar to estimates that are being produced now, even though this started back as far as February, of on the order of 0.5% to 1% is our estimate of the infection fatality ratio. So that's not, of course, again, it will be higher for those people who show symptoms, and certainly for people who go on to hospital, are serious enough that they need to be in hospital, that a higher proportion of them will be predicted to die of the disease. But it's really important that we get these estimates early on, one, to inform policymakers, not just how quickly a virus is spreading, but how serious it is, what toll it's likely to take in terms of deaths and hospitalizations, need for control. But also in order to understand when we do develop new drugs or test old drugs to see how they work on a virus, we need to know what the baseline is. How many people are likely to have serious disease or to die of this disease in order to know what we're going to compare it with, what sort of outcomes are we likely to see. So how quickly is it spreading and how severe is it? Those, of course, are two early things that we want to know. And then we want to look at, if we don't have a vaccine ready, which we don't, there are lots of people working on developing that, but it's not available yet. And we don't have clear treatments, although some drugs have been developed and are being tested. So there have been improvements in treatment that appear to be reducing the risk of death. But the fundamental thing that is in our control, both as a society and as individuals, is controlling our contacts with others. Because if we reduce contact with others, we reduce the opportunities for virus to pass from one to another. And in order to look at the possibilities of what sort of impact this could have, I was involved with colleagues at Imperial College in a report that we published in the middle of March that looked at what might happen if things continued in an unmitigated, sort of uncontrolled epidemic. Now, in a sense, when you do this, we're going to see numbers in terms of deaths per day that would never go unmitigated because people would change their behavior. But by doing mathematical modeling, using equations to extrapolate from what we're seeing now to what we might see in the future, we can say, well, what is this baseline scenario? What might happen? And so to look at that, then you see the increase from relatively small numbers. So these are deaths per day per 100,000 population. And you see it peaking. This shows numbers for Great Britain and also the US. The reason why the US shows a more a sort of flatter curve or less peaked is because it's more geographically dispersed. And so you get epidemics in different states, and that's what you see here in the different states, and those all come together to add up to this national epidemic. So you see more heterogeneity across the larger country that is the United States. So it also has a large number of deaths. So the total number of deaths over the course of this, had it been unmitigated, would be over 2 million for the US and on the order of 500,000 for Great Britain. Now, then once you've got those numbers, you can look at what possible control measures you might take. So this is corresponds to the do nothing, so unmitigated, versus alternatives that you might take. You might look at closing schools and universities, isolating cases, because if somebody shows symptoms of the disease and then you isolate them, you hopefully prevent some of the infections that they would go on to lead to had they not been controlled. Of course, case isolation can also involve household quarantine. So we've seen that as well. Social distancing for the over 70s, and all these things brought together. So all of these different scenarios were modeled in what's called individual-based simulation. So life is infinitely complex. So a model could never actually get to the full complexity of how we all move and all the decisions we make every day, but tries to get a useful approximation to the way the population moves and what opportunities are for control to advise on what sort of measures might be brought in. It can also look at the possibility of bringing measures in. So this shows having a sort of on-off, lockdown wasn't a term that we used at that point, but suppression strategy. So limiting contacts between the population. So you could imagine these are a projection for weekly ICU cases. So as they start to go up, you bring in this blue shows that you then trigger an intervention where you have a sort of stringent social distancing or some version of lockdown. You bring that in until the case numbers come down. Then you could, if you want, because of course lockdown has lots of other bad effects that we've seen in terms of social and mental health, but also economic impacts on people getting other forms of medical care. So you might loosen that, but then you would expect the ICU cases, like the case numbers, and then in a delayed way, the deaths will start to go back up. And you could imagine turning on and off these measures. Of course, we've now seen more nuanced where it's not just the same measures on and off, but it's a matter of balancing. And also, as you've seen, if you were watching the news just before we came online, of course, then the whole debate around Manchester and looking at regionally targeted estimates. So it's to give a sense of what's going on, to try and turn these measures on and off. These are, of course, the numbers that we've seen. So we had a peak in the late spring, and we're seeing another peak. It's important to distinguish between the period where we had targeted testing only, that's testing of people who were more severely affected, versus more mass testing available. And in fact, even the measures are more, sorry, my trash is getting taken out. These measures are more subtle because you have mass testing available, but they haven't been as much capacity everywhere through this entire time. So sometimes there have been regional limitations on the number that are available, and so that can reduce the number of cases that could be confirmed. So it makes it very difficult for us to compare offhand, just using case numbers, the number of cases that we're seeing now compared to the number that we've seen before. For that reason, sometimes we analyze the deaths due to COVID-19. And we can also bring in other data that weren't available in other epidemics, which are measures of mobility. If you carry a tracking device, like I often do, you are telling some company somewhere where you're moving around a lot of the time, if only because you have it on, and so therefore you're getting phone signal from somewhere. And so somehow the phone company will know roughly where your phone is by what phone signal you're picking up. If you have other functionality on, you've maybe tracked in other ways as well. So we had data from Apple looking at mobility over time, and you can see from a sort of baseline in late February, early March, this is for the UK population, we saw reductions of about 70% in our population measures of mobility. So we weren't tracking individuals, but just as a group, and we can do it on a regional basis, how people were moving around. And so that showed relative to the sort of this early stable point, how mobility changed. And we can use that to link it to the estimate of R over time, this reproduction number. What's the average number of cases? So it's not R naught, because it's not at the very beginning uncontrolled, but the average number of new cases that are giving rise. And then we can show in this plot here, where you see the purple, the link between the proportion reduction in movement. So we went down to as much as a 70% reduction in movement, how that brought down the R number. And of course, we want the R number to be less than 1. And you see that by the time we got to 70 or 70 plus reduction in movement, we did see it was lower. Now, the key and what we'd really like to do, of course, is be able to still move around for lots of the things that we do. And so what we hope is that by social distancing, by wearing masks, by staying, 1+ meter away from people when we're out, that we'll be able to, and we've got these analyses underway. This is really the relationship before we brought in strong social distancing messages. And what we'll be looking at then, because this was published in June, what we're looking at now is a new curve, and the red estimates show here things that were after the initial lockdown. And even as lockdown eases, we will start to move back up, so a smaller reduction in movement. And what we'd like to see is a much flatter line so that we can still get back to nearly as much movement as we were doing before, and therefore bring back all sorts of other social functions, but not to have transmission getting into an increasing trend. Thus the societal challenge. I've mentioned about the difficulty using case numbers, because if you have different amounts of testing available, you will sometimes be detecting a higher proportion of cases than others. We can look at deaths, but by the time that we look at death numbers, we have challenges in interpretation that when we had transmission happening in care homes more, we were seeing a higher number of deaths because the individuals in care homes were at higher risk when they got infected than younger people would be when they got infected. So the age mix of cases can affect what proportion of cases go on to die. And so how do we understand what's happening out in the population as a whole, regardless? One of the ways that we do this is, and this was a proposal that was a testing program that was brought together, Ipsos Murray and Imperial College London. We got funding to test over 100,000 people for virus a month. And so we went through these bursts of tests. And so what you see here, maybe just concentrate on the lower graph, is the proportion of tests, or sorry, the percentage of tests. So this is in percentage. So the very top of this is 1% of tests being positive, a random sample of individuals in England. And what we found was actually the fact that we couldn't deliver all the tests on the same day turned out is very useful, because then as we give tests over time, we can fit to the prevalence we observe, that is the proportion of in here shown as percentage of tests that are positive, and see that from the beginning of May to the beginning of June, we see a dramatic decrease in the prevalence of those tests being positive. Now, the lines give you a measure of uncertainty, and very early in May and late in June, the numbers weren't so high, but we have sufficient definition to show that there's a clear decreasing trend here. There appeared to be a bit of a blip up, but again, late June to early July, we saw another decreasing trend, which is of course what we want to see. It was flat-ish in early August, but then started to go up. And so each of these curves can then correspond to an estimate of R. So of course we want it to be less than 1. So our estimate for the first set of testing, and each of these batches represents between 120,000 and 150,000 tests that were taken out in the community, random sample across England. And that showed in late August, early September, an R estimate of 1.7. So considerably over 1, substantially over 1, and in statistical terms, significantly so. And it was then just after this that the rule of 6 was brought in, an additional push to limit contacts. In the latest round, it was reduced to an estimate of 1.16, but still significantly above 1. And then it was after this that then the 3-tier system is brought in. We need to have that R below 1. And even if we hover at about 1, we want to make sure that we have a low number. If we're going to stay relatively constant, which is what an R equal 1 will give us, we want to make sure that we've suppressed infections to a low level, because it's much better for all of us if we're going to remain constant to have constant at a low level of infections, a low level of hospitalization and death, than to stabilize it at those things being higher. This shows you the estimates. So the estimate, and there's sort of weighted and unweighted. The weighted allows for the fact that people don't randomly agree to take part in the survey. So if you adjust for the demographics, it was about 0.6% that were positive in this last survey. And that corresponds to about 450,000 people infected that we're picking up on any one day. And if people stay detectable for 10 days, that corresponds to about 45,000 new infections per day. So if you think about it, you've never heard for a single day when the government announces how many cases have been confirmed, anything like 45,000. So still, the majority of new infections are not being picked up. Now that's partly because people are, a substantial proportion of people are asymptomatic. They're not showing the signs of disease, but it's really important because they may still go on to transmit. And we get a lot of insight from this data into what's going on. This wasn't happening during the early phase of the epidemic. So what can be relied on? People have gone back and looked at blood donors, because of course people were donating blood even through that period, but blood donors are not a very random sample of individuals. It's a certain sorts. You have age restrictions, you have health restrictions, and there are other factors that may make people more or less likely to give blood. But it does still give us a measure of sort of up and down. And there's samples of blood given early in the year and during the peak for blood donors that can be tested. So I just wanted to end by sort of saying I've quoted from a number of reports. All the work that I've highlighted today has been collaborative with my colleagues at Imperial College in the School of Public Health. And there are a series of reports. There are peer-reviewed papers as well, but to try and get things in the public domain as quickly as possible. So far, there have been 33 reports that are there. So if you just Google Imperial College and COVID report, you will be sent here. We also have various scientific tools that you can look at of what are weekly projections for all European countries for deaths going forward for the next week and so on, as well as data resources and computer code if you're so inclined. In terms of data sources, I can just be a big plug for Johns Hopkins. They provide lots of data internationally, so you can look at, this shows the global numbers as of today. not too long before this talk, I took another snapshot of it. But you can see detailed data on a number of countries. And if you're particularly interested in the US, where of course Johns Hopkins is located, you can get state by state data as well. And I just wanted to end by a quote. So I gave the Bradford Hill lecture at London School of Hygiene, Tropical Medicine. And so when I was doing some due diligence to learn more about Sir Austin Bradford Hill before I gave the talk, I came across this excellent quote relating to real-time analysis. So all scientific work is incomplete, whether it be observational or experimental. All scientific work is liable to be upset or modified by advancing knowledge. And that is never more true than when looking at real-time analysis of outbreaks, because we're always learning new things, and it's important to be adaptive. I mean, there are oftentimes political pushes for once you've taken a position, once a politician has taken a policy position, that they should, remain true to that and show that it still was the right thing. But of course, when you're trying to control an epidemic, we may learn new facts. And if we get more data and more evidence, that may mean that, we need to adapt. And I think adaptive management is key to being responsive and doing the best we can. And along that lines, it does not confer upon us a freedom to ignore the knowledge we already have. So even if our knowledge is incomplete, and we know it is, and inevitably it is in the middle of an epidemic, we shouldn't postpone making a decision. We should make the best decision we have on the evidence available, but keep an open mind to the evidence that continues to be accrued, so that we can, at every point be making the best decision. Now, there are costs to that, in terms of that may mean that a message that you give at one point then has to change. And those are challenges for people other than me as a statistician epidemiologist. But I think these are sort of the inevitable thing of going through a major pandemic. And with each population having to look at those measures will change and adapt, sometimes be more focused, sometimes be more broad brush. But as scientists, we can but contribute the data and try and make those policy decisions as best informed as possible. But it's also important for us to realize that in the end, policy decisions are made up of a number of things. I mean, they can't just be science, particularly COVID science, because it's not the only thing people die of. And so if we end up with people staying home, and so people aren't getting the cancer screening that we need, and they're scared to go to hospital, even if they're showing symptoms of a heart attack, then you can have people dying of that. And that's one of the reasons why that there's also concentration, many things I didn't have time to talk about today, not just on the people who die of COVID related or identified COVID, but also excess deaths. So how many people have died in this region, in this country, worldwide, compared to what we would have expected from the last few years. And that'll give us the true measure of the impact of COVID on all of us. So thank you very much.